Our webinar today will discuss brain cysts, a treatment and care update. So my name is Jillian Demas. I'm the Senior Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today, Dr. Richard Peterson. Dr. Peterson specializes in neuro-oncology and neurology at Regents Hospital Cancer Care Center. Dr. Peterson has a strong interest in providing exceptional patient care and enjoys collaborating with multiple disciplines to deliver comprehensive care. He participates in multiple clinical trials nationally. Locally, he has supported the American Brain Tumor Association through the annual Humor to Fight the Tumor benefit, both as an attendee and as a featured speaker. Thank you so much for joining us, Dr. Peterson. You may now begin your presentation.
Great, thank you. So it is my pleasure today to be able to do this. Thanks to everyone for spending time with us today, and thanks to the ABTA for all the work that they do and for the opportunity to present this topic. So I'd like to outline some goals right off the bat. What we're going to do today is identify and define some of the different brain cysts that we come in contact with and see over the course of our practices, discuss the different symptoms that may arise, discuss the evaluation, and then discuss the different treatment options, prognosis, and then how to cope with this diagnosis, which sometimes can be difficult to do. So in terms of an overview, the first thing that I would like to say is, most importantly, that this is a group of non-cancerous lesions. There are a couple that we will talk about where transformation to a malignant tumor is possible, but this is exceedingly rare. Usually we find these cysts incidentally. So for example, someone comes into the ER with stroke symptoms, for example, and has an MRI or a CT scan, and we find a cyst that's in a part of the brain that is unrelated to the symptoms that are going on at that time. Now, just because these are non-cancerous, it doesn't mean that they are benign. So I frequently make this point with people because even a quote-unquote benign or slow-growing process in the brain can cause problems. And those problems usually are related to the location and the size of the cyst. And you will see this as we go through different examples, that this is a recurring theme. I think, though, that the other thing that's important is, from a patient perspective, it's scary to hear that you have some sort of cyst in the brain. It's easy for me to say because I see these cases and I see them over time and see that patients are stable and do well, but I think it's important to know that you learn this, and it can be scary, and understandably so. So a little bit of the who, what, when, and how. So how common are these brain cysts? Well, that's a difficult question to answer. The true incidence we probably don't really know, because many people could have them, don't have symptoms, so they never come to our attention. So an example of this, pineal cysts, and you'll see these in a bit, represent a fraction of 1% of the different tumors and lesions, including cysts, that we might see on scans over the course of a year. There was one study that took 1,000 patients consecutively, and 2 pineal cysts were found out of that 1,000. So these are uncommon, but how common are they? Well, we're not sure. If we don't look, we never find out, and that's one reason why the overall incidence is probably increasing over time, because there's more availability of better and better imaging all the time. So another example of this is a series where 48,000, so that's a lot of MRIs that were done consecutively over time, showed another kind of cyst, an arachnoid cyst, in 1.4% of those MRIs. So that comes out to 672 if my math is correct. But of those, only 5% were symptomatic, so only 34 of the 672. So you have to ask, well, how many of the remaining 638 would go undiagnosed unless we had more MRIs around to check on things? The truth is that we have the ability to do MRIs for patients who have headaches and tremor and other things, and whether we should be doing MRIs for some of those things on a regular basis is a whole other topic, but we do them, and so we find these things. Well, so who gets these brain cysts? For one particular type, the pineal cyst, there is a female predominance, but for the other cysts we will talk about, there's no real clear gender difference. Now, interestingly, with most other pineal lesions, there's actually a male predominance, but with the cysts, it's different. Usually, these will occur before age 50, but could occur throughout the course of life. And there's no clear difference in terms of race. So what causes them? Well, usually some sort of abnormal development of the nervous system, and we'll talk about this more. For some of the cysts, there is some correlation, for example, with head trauma or meningitis, which is infection or irritation of the tissues that are over the brain. Now, for most cysts, there is no correlation like this. There's no clear environmental exposures that seem to predispose to developing cysts. There could be potential genetic factors, which we will learn over time, especially since the human genome has been mapped, we will be able to discover these things over time. But I think that brain cysts are probably low priority, and there are not a lot of people looking at that. But over time, that is something that will come to light. So that's a little bit of the who, what, when, and how. Why don't we start talking about some of the different cysts and dive in. So let's start with the arachnoid cysts. So I got my pointer here. So these arise from the arachnoid tissue that cover the brain. And so here's the arachnoid. So this is a cartoon depiction. This isn't what it really looks like. You have the dura, which is the outside really tough covering, the arachnoid, which is just over the brain. And it's called arachnoid because if you look at this close up, then all of these little projections, they're not really this thick or look like this. They look like a fine web, essentially, so arachnoid. So it's this tissue, the arachnoid, from which these cysts arise. So how does this happen? Well, when the brain is developing and these tissues come together, there's supposed to be no real space there. But if these layers are separated, well then the arachnoid cells can create, they secrete a fluid, and so that can create a cyst. There is, as I mentioned, an association with trauma and meningitis. So trauma makes some sense because these tissues are on the surface of the brain. So if there's any sort of head trauma, then they're right there close to the line of fire. Meningitis, so the meningitis refers to inflammation of the meninges, and that's the tissues that cover the brain. So any sort of inflammation or infection could create problems with that tissue that could then lead to cyst formation. So there is this fluid called cerebrospinal fluid that kind of bathes the brain, surrounds it. It's in certain pockets that we'll look at that are in the brain. But the arachnoid tissue essentially covers the surface of the brain and the spinal cord. So there's a possibility that this could show up all along the brain and the spine. Most of these are located, however, in the sylvian fissure, and I'll show you a picture of that in a moment. This structure separates the temporal lobe from the frontal and parietal, but as I said, could occur wherever there is arachnoid tissue around the brain and spinal cord. Now, these could occur at any age. The ones that are symptomatic tend to show up at a young age. So here's a picture showing the sylvian fissure. Right? So this deep groove that separates the frontal and the parietal lobe from the temporal lobe. So the temporal lobe, as you would imagine, is on the side, the temple. So most of the cysts arise in this area, and so we have some pictures here depicting that. This would be the right temporal lobe. This would be the left, well, what should be the left temporal lobe, but it's being obscured and kind of pushed out of the way by this big pocket of fluid, this arachnoid cyst. And we can see the fluid that's in here is the same density, the same consistency as what we see in these other fluid-filled spots in the brain called the ventricles. So it's the same consistency as that fluid, the cerebrospinal fluid. So what sort of symptoms can these cause? The most common would be headache. The other concerning one would be seizures, because the temporal lobe of all the lobes is a little more predisposed to causing seizures. But based on the location, it could cause any other number of problems, such as hydrocephalus. I think you can even see that to some degree. Hydrocephalus essentially means water on the brain, taken kind of literally. But what it really means is that all this fluid, the normal flow of the cerebrospinal fluid, is essentially impeded in some way. And these fluid-filled spaces over here, and we'll see other pictures over time, but they're a bit, they may be a bit larger than what they should be because fluid is getting backed up. But when people get hydrocephalus, that can cause other problems: memory problems, balance, vision, even bladder control. Now, if an arachnoid cyst were more towards the back of the brain or near the brainstem, then you could see any number of other symptoms: weakness, numbness, double vision, other problems with coordination, even problems with chewing and swallowing. So this is true for arachnoid cysts as well as all of the other cysts that we will talk about, that we really only consider treatment if the cyst is causing symptoms, or if we see that it is growing and it's about to cause problems. Because the vast majority of the cysts really do not need treatment. In fact, some of the cysts, including arachnoid cysts, will regress over time. So we wouldn't want to put someone through potential surgery unnecessarily. The treatment is surgical. Ideally, if you can, you want to try to remove the entire cyst. If you can't, then you use what's called fenestration, or essentially you try to poke holes in the cyst to allow it to drain, which is perfectly fine because the fluid is native to the brain, so you're not inducing a foreign substance to the brain. If you don't remove the entire cyst, or if the fenestration is not successful, then sometimes you have to put a shunt in, and that is essentially a way of diverting the fluid from the cyst, usually into the abdomen, in order to provide adequate drainage. Otherwise, the cyst will just continue to reaccumulate the fluid all over again. So the second type of cyst that I would like to talk about is called a colloid cyst, and this is located normally in the third ventricle. So we've seen some pictures of the ventricles, and again, these are the fluid-filled spaces that are inside the brain. So these are the lateral ventricles. This is the third ventricle here, so that's where this tumor would show up. Now, interestingly, colloid cysts have similar properties to tissue in the respiratory tract. So again, this gets back to the whole idea of normal development, that as our bodies are being developed as an embryo, that tissues migrate into normal places that they're supposed to be. In this situation, the properties of these cysts are similar to respiratory tissue. So this tissue didn't make its way all the way to the lungs and was retained within the brain, essentially. Now, usually we see these in patients that are aged 30 to 50. Again, it could happen at any age, but that's the typical range. Symptoms of hydrocephalus. So again, that is a recurring theme, and again, the cerebrospinal fluid. If you see these bright things here, this is what's called the choroid plexus. So that's what helps make the cerebrospinal fluid, and the fluid essentially flows through the different ventricles, and there are different channels and connections between the different ventricles, if you will. So it's almost like a lake and stream, or lake and river sort of thing. And so if you block the river, if you block the flow at one point, then the fluid backs up. So symptoms: headaches, nausea, gait abnormalities, so problems walking. Now, one thing that separates these patients is that sometimes they'll have what are called drop attacks that has to do with the gait abnormalities, that patients will suddenly, inexplicably just, lose control of their balance and walking and then drop. They also have intermittent, sometimes very severe headaches that interestingly can be relieved by lying down, and that has to do with the way the fluid and pressure gets built up. That standing up makes it worse, lying down makes it better. Now, the colloid cysts, instead of having the spinal fluid, the cerebrospinal fluid, have a more viscous, mucousy kind of material, which makes sense because that's what you would normally find in the respiratory tract. So here are some pictures. You don't have to be a neuro-oncologist to see what's abnormal here, that here's this big cyst, right, sitting right in that area where the third ventricle would be, right? So lateral ventricles, and and right here in the middle is where you would see the third ventricle. And you can see here, I think, that the parts of these ventricles are blown up, that they are expanded because there's hydrocephalus there. And you could see down here, this is essentially post-op, that the majority of the mass, the cyst, has been drained and taken away, and those ventricles have started to decompress. They're coming back down to normal size. So treatment, again, is going to be surgical. This is the case for all of the cysts, that there's no clear role for radiation or chemotherapy. Surgery can be curative, depending on the size. It can be difficult, but again, can be curative if done. If you only try to aspirate, if you just try to suck out the fluid, essentially, there's a high rate of recurrence. The fluid will just reaccumulate. One thing that can happen with the colloid cysts is if they rupture, then they can cause a pretty significant inflammatory response, because the fluid in these cysts is not native to the brain. So it's a foreign substance. So that will cause inflammation and irritation. It happens rarely, fortunately, but this is a situation where this could affect a person's prognosis. I have seen a case like this where this happened, where a patient had a colloid cyst, was known. We were following it. It had been stable, but it ruptured, and it caused some pretty significant problems. Fortunately, that happens rarely. That's the only time I've ever seen that happen. Otherwise, the prognosis is very good because they may never grow, they may never cause a problem, and if surgery is possible, then again, it's curative. So, epidermoid cysts. Now, you might say, well, that sounds like skin, like epidermis, and you would be right, because these arise from the epithelial cells that you would normally see in skin. So again, as the body is developing and tissues are migrating into their normal places, these are cells that remained within the nervous system. There is some association outside of a developmental issue. There is an association with skin tissue that ends up in the brain, for example, due to head trauma, a penetrating wound to the head. This fluid, as you might imagine, because it's skin-related, is keratinized. It's kind of oily. The most common location for this is in the base of the brain, especially where the cerebellum and pons are. A location between them that's called the cerebellopontine angle, and I'll show you a picture of that. What can be difficult is that there are lots of nerves and arteries that are also in that area, and then those can actually become encased in the cyst, and that can help lead to symptoms and problems. So here are some pictures of the epidermoid cyst. This is the cerebellum that is towards the back of the brain. So this is the front, eyes, nose. You see the ears right here. So cerebellum, and then this is the pons right here. And normally that would be sitting midline. It would be sitting right there in the middle. So the angle that is normally created, you can kind of see it here between the cerebellum and the pons. So you can see that in that angle on this side, it's being filled with this tumor. So there are some arteries and there are some nerves that live in this area. One is the auditory nerve. So here are the ears. So the nerve that goes from the inner ear to the brain. The nerve that is involved in sensation of the face, that is involved in moving muscles of the face, are also right in that area. This is just another series, another picture in the series of MRI that gives us a different look at it. This is looking from the side, essentially. But we can see here that that this ventricle, again, looks like it is a bit big because fluid is backed up. So no surprise, recurring theme, symptoms are related to the location. Headache is possible, as I mentioned, loss of hearing, ringing in the ears or tinnitus, neuralgia, which just means nerve irritation or nerve pain, facial spasm, but you could also have problems with vision, balance, coordination that would correlate with parts of the pons and the cerebellum that could be affected. With involvement of different nerves and blood vessels, surgery could be difficult. But as with the other cysts, we would only do surgery if it was necessary. These cysts can leak on their own, spontaneously, or during surgery. Again, that could cause a non-infectious meningitis. This is one that fortunately responds well to steroids to help bring down any sort of inflammation. Prognosis overall is very good, even factoring in the location and complications from surgery or potential complications. This is one of the cysts that I mentioned earlier that could undergo malignant transformation. If so, then usually it is squamous cell carcinoma that would be diagnosed. If that were to happen, unfortunately, prognosis would not be good. But again, that is uncommon. How common is it? Well, again, we get back to the fact that these are relatively uncommon cysts to begin with. In looking through the literature, there was a review of 52 known cases in the literature at that time, and if I remember correctly, that literature review was done in 2005. So that gives you an indication that over the many, many years of medical literature that this is not a common occurrence. So we go from epidermoid to dermoid, and similar to at the epidermoid, this comes from cells that would normally be in the skin, right, dermis, that remain in the nervous system. And just like the dermis in regular skin, you could have elements of hair, sweat, and sebaceous glands. So the contents end up being similar to the epidermoid cyst, kind of an oily, greasy substance. Again, could present at any age, but tends to be young adults, even childhood. These occur near the fourth ventricle. So let me give you another different look at these things. So over here we see the fourth ventricle, right? And over here we see what we already have seen before, the lateral ventricles, the third ventricle, and then as we go down, closer to the base of the brain, then we see the fourth ventricle. And I tried to find a series of pictures that would give us a good look at what it might look like if one of these ruptured. I didn't find a good one. This is essentially showing rupture of an aneurysm or of bleeding that outlines the ventricles. And really this illustrates that if something like that, heaven forbid, were to happen, that the fluid and the contents would be distributed throughout that fluid space. So symptoms are related to location. Hydrocephalus, again, is a potential concern. Usually problems with balance, nausea, double vision. This is one, not often, but sometimes can actually remain or retain some connection with the skull. If that happens, then essentially you have something inside the skull that could communicate with the outside of the skull, and that can lead to infection. So there are cases where patients will have recurrent abscesses. And this could be a real problem because if rupture would happen with the dermoid cyst, then that could potentially be fatal, especially if it was an abscess, if it was infected. This, more so than others, could potentially lead to seizures. So here is a good picture of a dermoid cyst. And so lateral, this is looking front to back. So essentially you're looking from head on as opposed to top to bottom or side to side. So this is lateral ventricles, and this is third ventricle, and then the fourth ventricle is lower. But you have this mass that's sitting there, and then this is post-op. So these also could result from traumatic deposition of skin into the brain. Again, a penetrating head wound. Like the epidermoid, could undergo malignant transformation, although rare. Surgical resection can be curative, but like the others, if it's not completely removed, it will gradually grow again. Overall prognosis with the epidermoid and the dermoid cyst are really very similar. So the pineal cyst. This, like the arachnoid cyst, is most often found incidentally, almost always are asymptomatic. As the name implies, they are associated with the pineal gland. So where is that? So here are some different pictures looking at it. Here is the pineal cyst. So it's sitting behind those ventricles and above the brainstem. This is looking at it, from top to bottom. So ventricles, again, lateral ventricles, so it's kind of right behind the third ventricle. This is just showing that there's fluid in there that's about the same density and consistency as the cerebrospinal fluid. Usually these do not enhance. This is a post-contrast that usually tells us if something's very active or inflamed, and these usually do not enhance. So for what it's worth, and again, data are not always clear on these things, but estimates are that 85% of these remain stable over time. 10% will decrease in size. The other 5% could increase in size. So these are, much more similar to the arachnoid cyst, in that they tend to be much more stable, could even regress over time. Symptomatic cysts are more common in young females, which will then always lead to the question of what is the possible hormonal influence that could be going on there, especially since, as I said earlier, that most of the pineal region lesions, tumors, are seen in males. Symptomatic cysts tend to be larger at onset, which makes sense. The larger it is, the more likely it is to create symptoms. Hydrocephalus, again, comes up as a possible problem. And then the thing that makes this one unique is what's called Arachnoid syndrome, which really has to do with impaired ability to move the eyes in conjunction, especially up and down, more so with up gaze when trying to look up. You can also see nystagmus, which is where the eyes kind of bounce back and forth a little bit when trying to look in one direction. Patients will say they have difficulty focusing both eyes on an object. They can also have double vision. Again, resection here could be curative with good surgery. If it's not a complete resection, they do tend to come back again. Overall, prognosis tends to be excellent. These are not cysts that are known to transform into malignancy. There are some other rare cysts that I will mention here briefly. The Rathke cleft cyst is associated or found in the region of the pituitary. Very rare, the glioependymal cyst is actually found within the brain tissue itself. There are the choroid plexus cysts that are found in the ventricles. Again, the choroid plexus is that structure that we saw in the ventricles that helps make the cerebrospinal fluid. The data on these types of cysts are not as clear, so I wanted to mention them, but did not feel that I had enough to be able to really go in depth on them. So other things that I think we have to consider when we're talking about these cysts, that as you've seen, there are some typical features on CT or MRI for these cysts based on location and appearance, so that when we look at CTs and MRIs, we see that a cyst is in a particular location and has this appearance on this sequence of MRI and looks different on this sequence of MRI, and it helps us distinguish them. As good as MRI is, it's not perfect, and so sometimes the answer is not always clear. So what else can we do to help make a clear diagnosis? Sometimes we have to consider that something else could be going on. Is there an abscess? Is what we're seeing a representation of a a rare or more atypical tumor, or is there some other inflammatory condition like MS, multiple sclerosis, that could be causing these changes that we see on MRI. Sometimes we need to do a spinal tap or lumbar puncture, as we call it, which is a way of obtaining that cerebrospinal fluid to send it to the lab and analyze it in order to help make a diagnosis. As I said earlier, some of these cysts can arise in the spine as well. So sometimes we will, for example, see that someone has an arachnoid cyst, and they're also having symptoms that could be related to the spine. So we need to obtain MRI of the spine as well. So this is what I call the real world, or this is where the rubber meets the road. This is where someone finds out that there's a brain cyst, and then what do we realistically do from this point forward? Again, I think that when a brain cyst has been identified, it's natural to panic. I think that that's an appropriate response. That it's easy for me to say it's going to be okay because I've seen X number of these over 15 years, but it's the first time this has happened to an individual patient. And so I think that it's naturally concerning, and I think it's okay to call that out and identify that. The important thing is to know whether or not this is causing symptoms or not, because most of the time, these cysts don't cause symptoms and never will. Unfortunately, that is the case with the vast majority of these. So if someone has a cyst that we found, what do we realistically do moving forward? And there's not always agreement on, how frequent should we do tests. MRI is the test of choice. It shows us much more detail. So that's going to be the test that we would want to do. A lot of times we might do the first follow-up scan after first finding it. We might do it 3 to 6 months later just to make sure that it's nice and stable, and then go to yearly scans. But MRIs are not cheap, so how long do we keep doing that? I mean, do we keep scanning someone yearly indefinitely? This is what I do. For stable pineal and arachnoid cysts, I would consider stopping after 5 years. That's because the likelihood that these two types of cysts are going to cause a problem is much lower. And we know that these cysts are more likely to regress than the others. For the colloid, epidermoid, and dermoid, I'm more concerned about the potential complications of rupture, growth, or transformation, and that goes for dermoid and epidermoid. The transformation, not so much for colloid. I tend to continue yearly scans for those tumors. But this is something that we decide with each patient individually. If I have a patient who is very concerned about the pineal and arachnoid cyst, then sometimes we will continue to do scans after 5 years because that gives a person peace of mind, and it's important for their quality of life. Now, if a cyst does become symptomatic, it is very important to seek medical attention quickly. If we're going to intervene, we want to do things earlier before later. We want to be ahead of the curve. We don't want to lose our opportunity to have a good prognosis. So I did have a patient once who had a colloid cyst, who gradually was developing hydrocephalus over time, and did not seek out medical attention the way we might have wanted. And that patient, even after surgery and taking care of the hydrocephalus, never quite got back to the point prior to surgery. So there is sometimes a a point of no return, that even if we're able to go in and do and intervene and take out the cyst and take care of something like hydrocephalus, it doesn't mean that everything is reversible. So we always want to try to stay ahead of the curve. It's best to have a team of doctors who are experienced in dealing with things like brain cysts in order to do all the appropriate evaluations and, heaven forbid, if necessary, surgery. I would say this, that for many of these tumors, having a neurosurgeon who's experienced in what we call skull-base surgery is critical. So many of these tumors are near the base of the brain, near the skull, and so they could be deep, and they could be very close to very sensitive structures, which makes surgery complicated. So you don't want just any neurosurgeon. You want someone who's experienced in doing this type of surgery. Usually there's no role for radiation or chemotherapy, since surgery alone can be curative. Radiation and chemotherapy typically work best on lesions, on tumors that that are producing cells. And cysts just don't do that. You know, the only exceptions that we're talking about here would be the dermoid and epidermoid that could transform. But again, that's rare. After surgery, it's important to know that sometimes we may need to do some therapies, PT, physical therapy, OT, occupational therapy, speech therapy. If there are seizures or other complications, then we have to consider medications to address all of those symptoms moving forward. So sometimes, well actually I would say most of the time, I think time is the best medicine. The more time that goes by where we see stable scans is going to be therapeutic for both of us. That over time, I can relax and not be worried about it. A patient can start to understand that this is something that he or she was likely born with, that's been with them their whole life and will be with them moving forward, and most of the time will not cause a problem. That this is something that they will continue to live with as they have for as long as they've been alive. But it takes time for that to happen. I also think that it's important to ask questions at appointments. You should always bring at least another person with you to have another set of ears to hear things. You know, a big part of coping with a diagnosis like this is having knowledge, right? Knowledge is power. In a situation like this where you have an abnormal finding that may never cause a problem, you know, I think it's important to have the appropriate support moving forward. You know, if someone were to develop symptoms, then we deal with that and we move forward. But most of the time, things really are going to be just fine. So hopefully we have successfully achieved the goals that we outlined in the beginning, that we've identified and better defined some of the different brain cysts, the ones that we commonly see, discuss the different symptoms that may arise. Again, there was a big recurring theme there with hydrocephalus, and again, where the cyst is, the location, and the size. We discussed the evaluation, which pretty much consists of scanning the head with either MRI or CT. MRI would be preferred, but there may be other tests that would be necessary, scans of the spine, spinal taps. And then we discussed the different treatment options, which primarily involve surgery, prognosis, which in most cases is very good, and then how do we cope with the diagnosis? How do we move forward living with this? And I think that sometimes that takes time and understanding that this has been with me for a while, and seeing some stable scans over time. So I'd like to say thanks. Thanks to everyone for spending some time with us this afternoon. Thanks again to the ABTA for everything that they do, and I'd be happy to take some questions.
Thank you so much, Dr. Peterson. That was wonderful. So Dr. Peterson has some time to take some questions. Just a reminder, if you have a question you'd like to ask, please just type it and submit it using the question box in the webinar control panel on the right-hand side of your screen. So we have some questions that were submitted ahead of time, and we do have plenty that were submitted while you were talking. So I'm going to go through and give you a couple of those. First question is, how would you describe the visual disturbances caused by cysts in the pineal region?
Well, so that would so it could be varied. Right? The main symptom there is going to be patients often say they have difficulty focusing on an object. That they say they can't get their eyes to focus in one spot or converge on one spot. They will also say they have blurry or double vision. Usually they won't comment on the fact that they have a problem looking up or down. That's usually something that we see when we start to examine someone. So usually it's double vision, blurry vision, and the problem of focusing on an object.
Wonderful. Someone is asking, you touched on this a little bit, but you know, this is part of your job every day. How does an individual cope with knowing this is in their body? What recommendations do you have for them? Do you point them in the direction of, you know, social work, therapy, support groups? How do they cope with it?
Yeah, absolutely. Frequently we'll have people see our social worker or counselors, you know, because even though the prognosis is going to be good, you've still been delivered some upsetting news, and so I think it's perfectly appropriate to make sure that a patient has all the appropriate support services that they need. You know, sometimes if we see something. And I will have patients meet with neurosurgeons just so they hear it directly from the neurosurgeons, that they would not go marching in to take something out. But I think that you have to consider all of those things. Support groups, I guess that gets a little difficult because is it really a tumor? Not necessarily, but it could cause problems like a tumor. I've had a couple of patients who have had brain cysts, and they went. They didn't feel that it necessarily applied to them, but I think that would certainly be an appropriate avenue because a lot of the same potential symptoms and complications could arise. Brain cyst or brain tumor.
I definitely agree with you on the support group. It's difficult to find a benign type of group for this population, as well as, say, meningiomas, so something we need to work on.
Right.
A question is addressing something that you talked about, that, you know, they are cysts, but some talked about them as benign brain tumors because of the severity, and not just saying that they're a cyst in the brain. And you did work and probably will work with Humor to Fight the Tumor, which benefits ABTA. the person's asking if, why do we still categorize these just as cysts and not just brain tumors? Would it change the impact of funding on clinical trials and research and, just money for organizations? What do you think?
Well, it's a very good thought. Off the top of my head, my first thought is it's about numbers. So, are there enough brain cysts that are seen on a yearly basis to add sufficient numbers so that if we were to add them to the brain tumor numbers, would the overall numbers go up enough that we could bang our drum and say, look, we have this many brain tumors a year. We should get more funding for this. I'm not sure if the frequency would necessarily cause an increase. I think the other thing is that they're not true tumors. They're not true neoplastic tumors. That they're fluid filled, and some tumors can be fluid filled, but then those are also solid. So I think it does. You can get a little nitpicky with it for sure. I'm not sure that there would be enough numbers to make a huge difference, and I don't know. Maybe I'm wrong. That's just my initial gut reaction in thinking about it.
Sure, interesting thought.
Absolutely.
We probably have 3 or 4 people that are asking about how do you know if the headache is really from the cyst or if it's a migraine headache and is diagnosed as from another source?
Well, you don't always know because one of these cysts could be potentially causing migraine headaches. We don't always really know what causes migraine headaches. There are all sorts of different theories, but I've had plenty of patients with cysts who had headaches that would be textbook migraines. So you don't always know. This is why it's important that if someone starts developing headaches that are unusual or atypical or are more frequent, that would be a good reason to have a scan of the head. If there is a cyst that is very small and it's not putting any pressure, it's not causing hydrocephalus, it's not putting any pressure or impacting any of the surrounding tissues, it's going to be awfully hard to say that that cyst is causing headaches. If a cyst is going to cause a headache, then it's because it's occupying a larger space, it's causing hydrocephalus, it's starting to impact the surrounding brain tissues.
Thank you. Regarding the Carnot's, if I'm pronouncing it correctly, syndrome with Pineal Cysts, can these symptoms come and go, wax and wane?
Absolutely. Absolutely.
All right.
You would expect them to become progressively worse over time, but initially they could certainly wax and wane.
Okay. Good to know. People are wondering about recurrence and wanting to know about time frame, how soon they can come back, and how often a cyst can come back.
Well, so the cyst will almost always come back if it's not completely removed. Even if it is completely removed, there's always a chance it could come back. What is the time frame? Usually you're talking years These are things that may accumulate fluid very slowly over time. It is possible that they could come back sooner, but it tends to be something that takes a while to happen.
Someone's asking a question about a very rare type of tumor, neuroglial cyst or cystic astrocytoma. Do you have any information on that?
Yeah. So there are some tumors, some forms of astrocytoma that have cystic components, but are not true cysts by themselves. So that would fall under the category of brain tumors, specifically gliomas.
Oh, okay. And where would they? So they would seek out information more under astrocytomas?
Yes.
Okay, all right. So I can let them know, at the end of this I'll give out all our information, our contact information for you to call us. Have a couple more we have a couple minutes to wrap up. How likely is a stable pineal cyst to cause problems?
Highly unlikely. The pineal cyst and the arachnoid cyst, it's very uncommon for them to cause problems. That's why those are the two that I will sometimes stop yearly scans after 5 years. Those are the ones that worry me the least. If it's been stable, it's likely to remain stable. With the pineal cyst and the arachnoid cyst, if they're going to cause problems, then most of the time they're already large enough to do so when we first find them.
Wonderful. That's a good question to wrap up with, so thank you. That's all the time we have for the questions. I want to thank you, Dr. Peterson. You flew through tons of questions. We had a really popular webinar, so thank you. I want to let people know, as I promised, for more information on cysts or astrocytomas or any other brain tumor-related topics, you can visit our website, which is abta.org, or you can call us on our care line, which is 800-886-2282. So I'm just going to pause for a moment to stop recording.